Today we will discuss how do we manage the endodontic emergencies, which is the main cause for patient to come to our office, and the ability to relieve the patient pain is so rewarding and satisfying for the doctor. We will discuss how to manage the reversible pulpitis, irreversible pulpitis, necrotic pulp with symptomatic apical periodontitis with swelling, also the facial spaces swelling. For the reversible pulpitis, the cause of it may be caries, exposed dentin, recent dental treatment, or defective restorations. So the conservative removal of the caries, protection of the dentin, and proper restoration will typically resolve the symptoms. We can also apply the desensitizing agents on the dentin to close the odontoblast tubules and to relieve the dentine hypersensitivity. For the reversible pulpitis, we know that it is known for its prolonged episodes of pain, even after the source of the stimulus is removed. As an emergency act, we can ask the patient to bite on a cotton pellet that is soaked with ogenol until we do the treatment, which is the removal of the pulp, which is the cause of the pain. The whole removal is the most appropriate type of management. But in some cases where the tooth is multi-rooted or we do not have enough time, removing the pulp chamber and putting a cotton with ogenol, then closing the tooth must give the patient a big relief and rest. We should not do a partial instrumentation of the canals, whether we do complete removal of the pulp in the root, or we only remove the coronal pulp if we do not have time in that session. Also, antibiotics are not effective, so they are not recommended in these cases because removing the pulp is sufficient to make the patient with no pain. As for the pulpal necrosis with symptomatic apical periodontitis, whether we have swelling, the first thing we must do we must achieve a drainage from inside the tooth by opening the access, and it is not recommended to leave the pulp open and exposed to the saliva and the mouth environment. Also, there is a chance of getting foreign objects inside the canal if we leave it open like this. Here we saw that a foreign object has entered the canal because the access was open. So we allow the canal to drain the abscess that is inside in the radicular area. Then we do the crown down instrumentation technique, which removes most of the debris coronally rather than pushing it out of the apex. If we have a swell, we can push on the mucosa overlaying the swelling to help facilitate the drainage through the canal. Or we can, if it is big, we can do an incision and remove the and allow the pus to move out, incisioning the fluctuant swelling. Also, removing the necrotic pulp, which is the source of the infection, is important to relieve the symptoms and the case as all. These cases usually are done with multi-visits, So we use an intracanal medication, which is the calcium hydroxide, between the visits. For antibiotics, they may be prescribed if we have systemic manifestations such as fever and tiredness. The patient is feeling weak. Now let's discuss a emergency case that is actually dangerous, which is the facial space infections. The patient experiences swelling and mild to severe pain. Depending on the relationship of the apex of the affected tooth to the muscular attachment, the swelling may be localized to the vestibule or extend into the facial spaces. The patient may also have systemic manifestations such as fevers and chills. Rapid incision and doing drainage is crucial. Then we can decide if the tooth is treatable, to do a root canal treatment, or we do extract the tooth to remove the source of the infection. Antibiotics are prescribed in these cases with analgesics to decrease the pain, but they are prescribed after we do the drainage because we know that the pus and this inflammation suppress the reach of these antibiotic to the site, and we know that antibiotic also do not reach to the necrotic canal, so it's not as effective when we prescribed after we do the incision is more effective. The infection in the mandibular area can spread to the submental area or the submandibular area or the sublingual area. And in cases when the pus is spread in the three spaces at once, we got what is called the Lotfing angina. That is life-threatening because it can reach us to the airways and causes in the pharyngeal space and causes obstruction of these the airways of the breathing airways. In this situation, the patient is referred to a care center to do the appropriate management for this emergency case. For the maxillary cellulitis or infection, it happens between the corticobuccal plate and the buccinator attachment muscle, and the tooth is usually below the attachment of the buccinator. Also, it can reach the orbicularis oculi muscle from the canine space and the buccal space, and this is considered a dangerous zone. Also, this zone is so dangerous because the cervical, it is so close to the airways. So, how do we manage these cases? Here they are saying that incision of the drainage is indicated whether cellulitis is indurated or fluctuant. And as I've taught before or known before, that the fluctuant, which means that the indurated, which means when the pus is still hard, should not be touched until it reaches the fluctuant stage, when we can see that the skin is a bit wavy. This is what I have studied before, but here they are saying that whether in both cases we must do the drainage. So if any of you doctors have knowledge about this, please inform me about it. The incision for the drainage allows the decompression from the increased tissue pressure associated with the edema and can provide significant pain relief for the patient. The steps are: we first of all anesthetize the area around the swelling and never anesthetize through the infection to prevent any spreading of it. Then make a vertical incision in the site with the greatest swelling portion. Then start pressing gently into and activate the pus drainage. Use clean, warm salt water to rinse the site, and use an intraoral warm gauze to press the swell from the inside. This will cause a dilation of the small vessels and will intensify the host defenses through the increased vascular flow. Then we apply a drain that in its simplest form is composed of an iodiform gauze that is cut to a proper length, and it is sutured to the site to prevent its closure. And the patient should come after 24 hours for the removal and to recognize if there is any enhancement in the situation and the degrees of the symptoms. If you find that the symptoms has increased and there is an elevated body temperature, a central nervous system changes, and airway compromise, then it should be referred to an oral surgeon medical facility for immediate care and intervention. As for the antibiotics, they are stopped after 2 days of the relief of the resolve after the symptoms are resolved. Now, if we have asymptomatic teeth with the previous endodontic treatment, and this is for me is a nightmare, to be honest, the goal remains is to remove the necrotic teeth, which means that we must get a reach to the apical area to make a drainage from the canal. But if the canal is blocked with posts, and we have ledges, or we have broken files, and we cannot get access to the periapical tissue, we must get an evaluation of the case before we start, because failure to complete the root canal department removal and achieve a periapical drainage may result in continued painful symptoms. So we can refer the case to an endodontist, or we extract teeth if it is unrestorable. Here we can see that in 3 minutes, this is the first we open the tooth. This is after 2 minutes, and this is after 3 minutes. After 3 minutes, we had a great drainage and great relief of the pain. Leaving the teeth open between appointments is not recommended. The analgesis, the most famous one we know and use, is the ibuprofen. We know it's a contradiction for the gastrointestinal problems patients and pregnancy. In pregnancy, we should not use it. If the patient is taking aspirin as a daily doses, making a combination between the aspirin and diclofenac is more effective than the combination between the aspirin and the ibuprofen. Let's talk about the flare-up. The flare-up is defined as an acute exacerbation, acute symptoms that happens between the appointments, or after we finish the treatment. Fortunately, there is no decrease in the endodontic success for cases that had treatment flare-up. It happens for a variety of reasons, including the preparation beyond the apical apex, the over-instrumentation, pushing the dentinal and pulpal debris into the periapical area. Many of these cases can be pharmacologically managed. Finally, let's discuss the cracked and fractured tooth. In the early stages, the cracks are small and difficult to discern. If the tooth is vital, we first know the extent of the crack. If it's not deep, we can fix the problem with doing a restoration or doing a full crown. Its symptoms are sudden and sharp pain, especially during the mastication. And we know that the bite test is an important test to do a differential diagnostic, where we do the bite on each cusp by itself to know where is the crack in particular. But if the fracture is non-vital teeth, we must determine whether the crack or fracture was the cause of the pulp necrosis and whether there has been an extensive periodontitis breakdown. If so, the prognosis for the tooth is generally poor and extraction is recommended. We can see in this case the radiolucency around the root, a big wide lesion. Under the transillumination, we can see the borders of the crack. When we used a dimethylene dye, we have seen the extent of the crack that has reached the root. So we did an extraction. That's it. See you soon. Management of endodontic emergencies. Irreversible pulpitis. Prolonged simultaneous episodes of pain. Patient bites on cotton pellet with 𝐏𝐚𝐿 relieves the pain. Complete removal of pulp tissue relieves the pain, so no antibiotics is recommended. If the tooth is multi-rooted and there is no enough time, removing the pulp chamber relieves the pain also. Symptomatic apical periodontitis. Teeth should not be left open for drainage. Crown down instrumentation technique prevents pushing debris out of the apex. Intraocular swelling. Tissue swelling may be associated with an acute apical abscess at the time of the initial emergency visit, or it may occur as an inter-appointment flare-up. Swelling may be controlled by establishing drainage through the root canal or by incising the swelling. Antibiotics may be required when there are systemic symptoms such as fever and malaise. Once the canal have been cleaned and allowed to dry, calcium hydroxide should be placed and the access properly sealed. Fascial space infections. Clinically, the patient experiences swelling and mild to severe pain. Depending on the relationship of the apices of the affected tooth to the muscular attachment, in such cases, treatment may involve incision for drainage, root canal treatment, or extraction to remove the source of the infection. If the submental, sublingual, and submandibular spaces are involved at the same time, a diagnosis is lid-wing angina. This life-threatening cellulitis can advance into the pharyngeal and cervical spaces, resulting in airway obstruction. Antibiotics and analgesics are recommended after doing the drainage. The basic principles of incision for drainage are as follows. Anesthetize the area around the swell. Make a vertically orientated incision. Promote the drainage. Warm salt water mouth rinses. Intraocular heat application to infected tissues results in a dilation of small vessels to increase the vascular flow. A drain should be placed to prevent the incision from closing too early. Half-inch iodoform gauze. The patient should be seen the following day to remove the drain.